Good evening, esteemed members of the Pharmaceutical Society of Kenya. Good evening and welcome our able sponsors for the day, that is Dawa Life Sciences, represented by Martin. Good evening, senior respected members of the Pharmaceutical Society of Kenya, officials from the various branches. I can see that Dr. Yaile Anthony, the chair, South Rift, is here with us today. Welcome to today's webinar. Welcome to today's meeting. Today's meeting is on a new combination therapies in management of in diabetes management, new combination therapies in diabetes management. It is held in partnership with none other than Dawa Life Sciences. Dawa Life Sciences is a local manufacturer in Kenya. They have partnered with us before, and this is just them continuing to partner with us and strengthen the collaboration with PSK. So we are going to begin when we get to 300 attendees or at 7:05, whichever comes first is which we are going to follow. And I want to welcome you to today's meeting. And as we probably kickstart the meeting, I want to understand probably for us to see and to also carry on the conversation. Do we understand what our role as pharmacists? Do we understand probably as stakeholders in the pharmaceutical sector? What are the key areas that we can look into in terms of tapping into UHC? So let me see on the chat box. Type your name and probably let me know what areas we can look into in terms of UHC. Just that is for us to take to get to understand this conversation on UHC. I'll have a reason to why I'm asking the question on UHC, and I'll comment about it as we complete our webinar today. So let me see if let me see on the chat box what is our main role as pharmacists in achievement and attainment of UHC as a country goal. Just your name and probably give us what we stand to achieve as a country. And I will read out this probably towards the end, and having in mind that I have a main goal for sharing that. Thank you very much, Dr. Bill Ouma, saying, Dr. Bill Ouma says is affordable healthcare, and Dr. Dorothy says is to avail health products and technology at affordable cost. Dr. Ouma, Bill Ouma continues and says that it's a matter of accessible healthcare services. Accessible healthcare services, or today in the morning, it was coined that it is accessible health. Accessible health as a whole means that we are able to access, our citizen is able to access health. Dr. Nadia Bat says we need to include community pharmacy at UHC. That's a very good conversation she is raising there. We're going to tackle it in one, I'm going to tackle it in one of the pointers that I'm giving tonight. Dr. Farhia Hussein, this must be pharmacist from Garissa, says that accessible and affordable healthcare services. And Dr. Clarice Ambale, a pharmacovigilance pharmacist, says prevent catastrophic expenditures in accessing healthcare. Again, the point of access and the cost is coming in loud and clear to us and to us as pharmacists, and also as members of the healthcare team in the country. Dr. Frederick Gidenji says resilient and responsive health supply chain. And Dr. Annie Moneki says it's readily available continuous glucose monitors in Kenya. Wonderful. Dr. Wanjiru Njogi says to offer quality, affordable healthcare. To offer quality, affordable healthcare. That's wonderful. I love the discussion, probably the chat on the chat tonight. Dr. Joseph Mutura says geographically and economically accessible to healthcare. Ladies and gentlemen, I had assured you that we're going to begin at 7:05 or closest to 300. Karibuni sana, esteemed members of the Pharmaceutical Society of Kenya, respected seniors of the Pharmaceutical Society of Kenya, and the honorable fellows of the Pharmaceutical Society of Kenya is joining us, including members of the National Governing Council, today being represented by none other than Dr. Anthony Yaile, the PSK South Rift chairperson, and also members of the National Executive Committee. I want to welcome you to today's webinar. Today's webinar is sponsored by none other than Dawa Life Sciences. Dawa Life Sciences is a Kenyan manufacturer. We're going to go through combination therapies in diabetes management. Allow me to probably take you through a few ground rules. Before that, I want to introduce our speaker for today. Our speaker for today is none other than Dr. Dorothy Aywak. She's a pharmacoepidemiologist and a pharmacist at Kenyatta National Hospital. She is also the secretary of Hospital Pharmacists Association of Kenya. The question there is community pharmacy. Dr. Nadia, thank you very much for raising that question. If we are to include community pharmacies in UHC, how best are we bringing them out? So a few ground rules. First and foremost, thank you for participating in this session. Participants are muted during the entire course of this session. Please ask your questions via the Q&A tab at the bottom of your window. Questions will be addressed by the presenters on the Q&A tab. For PSK members, if not already done so, please subscribe on the PPP portal for the CPD points so that you can get your CPD points. CPD points will only be awarded to paid up PSK members. For KPA members, the attendance list shall be shared with your officials for awarding of CPD points. What to note is that the session is being recorded. It will be made available on PSK's YouTube page. So probably this is the reason to why I want us to discuss our role as pharmacists in attainment of UHC and why we are going for UHC. I'll come back to this towards the end of our discussion today. So let me probably introduce our agenda. We're going to have welcoming remarks. I will be doing the welcoming remarks. After that, you're going to have Dr. Dorothy Aywak presenting, after which you're going to have Dawa Life Sciences present, Q&A, then vote of thanks. So ladies and gentlemen, allow me to stop sharing. And now it gives me the singular pleasure to welcome none other than Dr. Dorothy Aywak, a pharmacoepidemiologist, a member of PSK, and also the secretary for the Hospital Pharmacists Association of Kenya. Dr. Dorothy Aywak, karibu sana daktari, you can share, and we begin our evening with you.
Thank you very much, Mbao, for that introduction, and thank you very much, Martin, for partnering with us in this session. I want to hope that I'm audible, like probably a thumbs up or something will tell me, okay, I'm audible.
Yes, you are, daktari, and you're well visible.
Okay, thank you. I think I want to also hope that you can see my slides in slideshow mode.
Absolutely, daktari, we can see your slides.
Okay. So thank you to all those who have joined us. I'm seeing we are almost getting to 500. So I'm hoping that we are going to leave having learned something. So I'm just going to introduce this topic today, the combination therapies in management of diabetes. I know we had previous sessions where we've highlighted something about diabetes. Today, I'm just going to focus particularly on two agents and their role in management of diabetes. So this is just a little bit of an overview of what it is how I'm going to structure my presentation. We're going to start with a little diabetes refresher, meaning that at that point, I will ask you some questions, or I'm hoping that we have an active and participatory audience and that you will be able to respond. Then we just go through the treatment options. What does the guidelines say? Then we are going to look at two classes that are two new classes for management, and then also what do we want in terms of patient education. You see, it's important, it's good we know we get new information, but we need to know that we can adequately communicate this. So just to start, so that I can, if I can have in the chat, what is your understanding of diabetes? What is diabetes? I know we've had this before. So if in the chat, you can just put, what is diabetes? And then what are the types of diabetes you know? So we can just have that in the chat and we can review it at some point during this session. And I'd like that, Mbao, you'll help me be able to check the chat. You'll probably put your hand up. I see whether there are any responses coming in yet in terms of what is it that we understand diabetes to be. What types of diabetes are we familiar with? Have we interacted with? We have patients, or we have family members who are diabetic. So what type of diabetes are they having? And then in our facilities, what do we have in terms of treatment for diabetes? What agents do we keep in our facility? Do we have the insulins? Do we have oral agents? Do we have the newer molecules? You let me know when we start getting some responses. I'm not seeing any yet. So with that in mind, I'm just going to go straight to the session. The treatment options. I'm hoping that we are not waiting to see the treatment options and then you decide to, it's an open book test, but adult learning, we need to be open. So I want to hope that I will be seeing the options. Okay, yes, I've seen that most of us know the type 1, type 2 diabetes. We understand diabetes is a metabolic disorder. Thank you. Yes, Eric says hi. Hi to you, Eric, also. So what are the treatment options that we have? This table will highlight the various agents. Some of them we have known them, we have interacted with them, we have been dispensing them. We might have patients who are taking them, or we ourselves might be taking them if you happen to be diabetic. The metformin is a very old drug, and we have, I think a number of us are quite familiar with it. We have the sulfonylureas, there's thiazolidinediones. Yeah, I'll ask, what is an example of a thiazolidinediones? Because usually we put a lot of groups and we need to just remember, do we know what drugs are in these classes? And in this table, I've highlighted, just summarized, what are the main advantages of these drugs? Like we see metformin is weight neutral, and the disadvantages, we have the complaints of GI side effects, lactic acidosis. Then we have the sulfonylureas, that is our glycoside, our the glibenclamide. Most I think of our healthcare facilities, they don't miss that glibenclamide. So we have the main disadvantage of weight gain and frequent episodes of hypoglycemia. When we look at the pioglitazone, we are thinking of fluid retention. Weight gain is still a challenge. And now here I'd want to highlight for where there are disadvantages of weight gain. Remember that there are diabetics who also are struggling with weight, and weight is an issue, or maybe they're obese and they're diabetic. And therefore you want to make sure that it's a molecule that the molecule that will be administered is not going to worsen the already existing condition. We have the insulin. The disadvantage with that is there are those who have fear of injections. So as much as you know it's a good drug, you have to deal with the fear of injections from the patients. Then we have what we have here lower in the list, the DPP4s and the SGLT2 inhibitors, which we're going to discuss at greater length in this presentation, and to at least be able to see where do these various classes fit. I'm just going to remind us, I hope we have that in the chat that we have those who have joined us, being able to just share what is it that they have in their facility in terms of management. In this chart, this is from the Kenyan Diabetics Clinical Guidelines. For a patient whose HbA1c is less than 7%, then that patient will say you can just be managed on lifestyle modification. For a patient whose HbA1c is between 7 and 8, then that's a patient who has to be started on metformin, and you check within in 3 months. Remember, for the glycated hemoglobin test, there's no benefit is checking every week. You wait for 3 months, then you see whether there's any improvement. And then you increase the dose until the tolerated dose. When their HbA1c is even worse than that, 8 to 9, then that's a patient who needs to start on dual therapy. So you will have metformin, and then you add a second drug from any of the groups. The guidelines give us the sulfonylureas, the DPP4s, the pioglitazone, that's the long name, the thiazolidinediones, the GLP agonist or the SGLT2 inhibitors. And then finally, those whose HbA1c are much higher, more than 10%, these ones have to be on insulin therapy. So you'll have to do a lot of patient education. If it's somebody who is not accepting insulin, that you can be able to encourage them and motivate them to get onto treatment. And then there's a monitoring that accompanies that. Now, from that chart, we have seen that there'll be a dual therapy, there'll be combination therapy. We start with one molecule, you see how the patient progresses, and then you will end up having to add to the treatment. And the challenge with many patients, when you give them the pill, quite a number of pills to take, then they already feel demotivated. So, but now we start thinking in terms of patient education. What do we need to be able to tell them? We need to be able to remind them that in the long term, monotherapy tends to fail. So you will end up being on combination therapy. That when we are adding an additional molecule, the aim is to be able to achieve optimal glycemic control. And what is this optimal glycemic control? I'll take you back to the guidelines. We want the patient to be below 7. But then again, you need to remember that depending on the characteristic, the individual characteristic of the patient, you're not going to enforce very strict controls to get them below 7 if it's going to be at the risk of hypoglycemia. So your therapy is going to be very individualized. Then again, combination lowers the risk of, when you are on the combination therapy, you have effective glycemic control, so you reduce the risk of diabetes-related complication. So I think even before I get to that slide of diabetes-related complication, and to see, do we know any of these complications of diabetes? I'm just seeing emails. Do we know any of the diabetes complication? Those who are online. One diabetes complication. If I give you a hint, eye, kidney, okay, good. Retinopathy. What else do we have as a complication? Nephropathy, glaucoma, neuropathy, peripheral kidney failure. Okay, everything pathy. So, okay, a diabetic patient ends up feeling very pathetic. I'm saying, yes, peripheral neuropathy. So it's all diabetic foot. Thank you. I'm glad DKA, especially when they're poorly controlled patient, DKA is a emergency. Yes, diabetic foot. Thank you. So at least I'm glad that we're appreciating that we know the various HONC. Yes, the hyperosmolar hyperglycemic syndrome, HHS. So I'm glad we are appreciating that there are different complications. There are a number of complications that a patient who is diabetic is going to face. And now when you give combination therapy, you're trying to achieve the optimal glycemic control so that you can reduce these complications. So a number of the new agents have additional benefits. You'll find either they are cardioprotective or renal protective, and therefore they add value to the patient. So we'll start with our first agent for the day, the group which is in the DPP-4s, dipeptidyl peptidase 4 inhibitors. I like to just think of them as the gliptins. So these gliptins, we have a number of them, the vidagliptin, saxagliptin, alogliptin, dinagliptin, sitagliptin. Yes, and you can see the structure. I think in a pharmacy class, it's difficult to move around without thinking about the structure. So just to have an idea, which of these DPP-4s do we have in our facility? Yes, erectile dysfunction is a complication. Which of these DPP-4s do we have in our facilities? I hope I've not blocked the sitagliptin, okay. Dara says you have sitagliptin, we have Benjamin, vidagliptin, we have some vidagliptin. Okay, there are some facilities which have the 3, Lina, Sita, and vidagliptin, sitagliptin. Yes, so we have a good number of facilities which either have the vidagliptin or the sitagliptin. And I'm seeing one was teneligliptin. Okay, well, that is as private facility. It's good that at least we have interacted with this molecule. So I want us to appreciate what value these gliptins add to the care. We start by looking at how exactly do the gliptins work. When the patient ingests, we say they have taken their meal, lunch, breakfast, whatever they have taken, the food gets into the small intestines. In the small intestine, there's a hormone, the GLP-1, the glucagon-like peptide 1, that is responsible, I'm trying to get my pointer, that is responsible for stimulating insulin secretion and also suppressing glucagon secretion. Why do we need the insulin? We need the insulin to get into the blood so that we can be able to absorb the glucose. We get the glucose into the cells. So what happens? The half-life of this GLP-1 is very short. You find that in about a minute, I think it's less than 4 minutes, it's already deactivated. So now what the gliptins will do will block the inactivation. They will block the inactivation or the degradation of GLP-1. We have the DPP-4 enzyme, which comes to inactivate the GLP-1 hormone. So when you give the gliptin, you're blocking this so that the GLP circulates in the body for a longer duration. What does that do? Just as a reminder, it's the same, just representing the same mode of action in a bit more detail. You have GLP-1 is an incretin. When we are talking about diabetes, sometimes you hear people say the incretin, the secretin. So it's an incretin. So what does it do? As a reminder, works on the beta cells in the, it is labeled, I'm hoping we know where the beta cells are. Looking for the charts to see if someone tells me where the beta cells are. So we work on the beta cells in the pancreas to increase insulin production. When the insulin is produced, it is going to reduce the circulating glucose. Remember, in a diabetic patient, you have hyperglycemia, a lot of glucose in the blood. Then additionally, it is going to inhibit the alpha cells. The alpha cells are responsible for encouraging glucagon release. So if you inhibit this, you are blocking glucagon. So you will end up reabsorbing. You will not have glucagon in the system and you have more insulin. So you will not have glucagon release. So what is stored, the glycogen will not be broken down to increase the amount of insulin in the system. So I hope we are together. I was taking the task. So what is the utility? What is the use? Why do we need gliptins? I mean, we've been having the glibenclamides, the other older molecules for a longer time. Why do we need them? Remember, if you can remember what I displayed in the earlier chart, the challenge with sulfonylureas is weight gain. So the gliptins are very helpful in patients who are overweight, who are obese, and in the elderly patients. Why? Because they have a lower risk of hypoglycemia, which is very important when you're dealing with the elderly and cardiac patients. And then they also have no influence on weight gain. So for a patient who also needs to work on cutting down their weight, then this is quite a good molecule to use, a good group to add to the combination therapy. It can also be safely combined with other agents like insulin, and it has a potential. It is not quite they say the cardiovascular outcomes are debatable, but there's potential for cardioprotection. Now, when we look at the various gliptins that we have the Sita, Saxa, Alo, Lina, Vida. For a patient, we know that a number of the diabetic patients might be having other comorbidities. They will be having chronic kidney disease or another form of kidney injury dysfunction. So what do you need to do? You need to reduce the dose. For majority of them, you reduce the dose by half, like when you're dealing with sitagliptin and vidagliptin. The other molecules that you may not require any dose adjustment, like the linagliptin. Now we'll move to our next molecule, the sodium glucose transporter inhibitors. Here I prefer to think of them as the gliflozins. So which gliflozins or SGLT2s do we have in our facility? So as I wait for that, I think we'll answer questions. I'm seeing a question after how long we say, because we know dapagliflozin. Any other gliflozin we have in our facilities? EMPA, we have, most facilities have EMPA and empagliflozin and dapagliflozin. So a large proportion of us are having the empagliflozin or dapagliflozin. Thank you. So now let's have a look at how this works. Now, how does the SGLT2 work? I hope this representation, this diagram is clear. But what I want to represent is that what the SGLT2 inhibitors do is block the reuptake of sodium and glucose. So they block the sodium glucose co-transporter. It is, I hope it is, the cursor can demonstrate that at this point in the renal tubules, you're blocking, and most of the blockade is on SGLT2. It's an SGLT2 inhibitor because we know that the enzyme SGLT2 is responsible for 90% of glucose reabsorption. So you want to be able to get a product that is actually going to target, to give you the best benefit. And if you have it selective for SGLT2, then you have better results. And now what does that do? It gives you additional benefit because now when you increase diuresis, that's the loss of fluid, the loss of the glucose, the loss of the sodium, you end up having the patient benefiting in terms of when we're talking about cardioprotection. The patient is going to benefit because it's going to reduce arterial stiffness. It's going to reduce the volume of blood. It's going to help in reducing the body weight. It's going to reduce the hyperglycemia and DKA. It's going to reduce glucose toxicity because you're excreting most of this out of the system. For patients who are already heart failure patients, it's going to stop the progression of heart failure patients. Now we know what the medicines do. It is one thing to have a very good molecule. It's another thing for that molecule to actually work. And we say the drugs will not work in patients who don't take them. That's a quote from Everett Koop. So how do you motivate the patients to take this medicine? Now, knowing what you know about the science, they could just have an idea. How do you, for those who have joined us, how do you motivate? Now that you know there are gliptins, there are gliflozins, the patient will not think about the dipeptidyl, the DPP4. What is it about that you've learned about these two molecules that will help you be able to make a patient appreciate their role and how it is going to work? How will you explain this to a patient? You must feel like picking from the respondents. Like Ransom, you have empagliflozin in your facility. You need the patient to be able to take the empagliflozin with as a combination therapy or in their diabetes management regimen. What are you going to tell them about the gliflozins that is going to encourage the patient to take them so that they actually achieve their glycemic target? Remember, diabetes is a chronic illness. It will not just disappear. It's not an infectious disease. It will not disappear, run its course. So what is it that you're going to tell them so that they can make sure that they preserve their beta cell function, that they can be able to reduce the likelihood of getting the diabetes complication? I hope they're about 7 and okay. Convenient dosing, no weight gain. Thank you, David. You'll be able to tell them that this new therapy is going to help you in terms of convenient dosing. It's going to deal with weight gain. Thank you, Emily. You say it's going to protect your heart. They are cardioprotective. Any other responses? They don't cause weight gain. They are cardioprotective. Thank you, Edwin. Say the same way drugs don't work in patients who don't take them. Knowledge doesn't work in people who don't use it. Okay, Samuel, you say it lowers the BP. You reduce the glucose toxicity. Thank you. I see Galaxy M31. Tomorrow, when you're back at your facility and you see the patient has been added a new agent and they start telling you that now this new medicine, this either gliptin or gliflozin you've added to my therapy, it is too expensive. So what is going to guide you? What is going to help you make the patient adhere to the new regimen, take the new regimen? In heart failure patients under the DM, I want to assume, Margaret, you meant to say that for heart failure patients who are diabetic, that it is beneficial, it's cardioprotective, it's nephroprotective, you're going to reduce kidney damage. Now I want to ask now, how do you explain cardioprotection? You may not answer it in the chat, but just think about it. How will you explain cardioprotection to the patient? How do you explain nephroprotection? We can say, yes, your kidney, you can have kidney injury and you find yourself coming for dialysis. We want to make sure that you don't find yourself as a routine dialysis patient. Yes. So just be thinking about how do you, when you've known the science behind the medicine, how are you going to make sure that that science is going to help you make a difference? Thank you. And the benefit the drugs come with. Okay. So you've highlighted this. Remind the patients, what are the complications of diabetes? You want to make sure that they, you'll ask the patient, do you want to make sure that if you're driving yourself around, you're busy, you're active, mobile, you don't want to say that you're having glaucoma or cataracts that's interfering with your vision, because if you can't see, it really limits your mobility. Yes, I know those who are visually impaired can still find a way of getting around, but if you had not been born visually impaired and now you become visually impaired, it also will impact on your psyche. For those who have had heart failure patients, you want to reduce, if they had had a stroke before, you want to reduce the likelihood of them having a stroke or a heart attack. You're thinking of the pins and needles, then your peripheral neuropathy. You'd want that that complication. You want to ensure that they do not face that complication. So if you remind the patient, if they have either encountered or somebody, maybe they're in the clinic and they find there's a fellow patient who has a certain complication. So you can use that to remind them that, we want to avoid you getting to this stage. Not pointing at the patient who has probably diabetic nephropathy, but you want to just remind them that if you don't take your medication and you don't take optimal therapy, then you will end up risking getting these diabetes complications. So how are these, how do we combine these various therapies? So this I have lifted from the KDIGO, the renal guidelines, that for a patient, they start off first with their type 2 diabetic patients and they have chronic kidney disease. You start off with, depending on the glycated hemoglobin status, you start off with physical activity, the nutrition, weight loss. Then the first line therapy is metformin and an SGLT2 inhibitor. However, if the patient's eGFR is less than 30, then you do not initiate SGLT2. That's a patient who will use any other of these other agents. The GLP-1 receptor agonist, there's the liraglutide, but I think a number of facilities don't have the GLP-1 receptor agonist, the DPP-4s, the insulin, sulfonylureas, thiazolidinediones, and the alpha-glucosidase inhibitors. I don't know whether we really have this, the acarbose, in any facilities, but that is the plan. When you're taking the patient to what is it that is in their therapy, when they see the therapy changing, what is the rationale for why has it changed? Don't just tell the patient, Daktari amebadilisha, the doctor has changed. Try and explain to them, because remember, like what I'd said, drugs don't work in patients who don't take them. Try and break down the science of what it is you know about the treatment regimen, the way the drugs work, to help the patient be able to be an agent in their choice. So when you're engaging the patient, let them know. Sometimes you can use the same methodology our parents used to have when you ask them, why should I eat some vegetables? And the answer is because I said so. Okay, well, that you need to find a way of how to explain to the patient, but you need to have the patient be able to rely on you, to feel like they trust you, that when you give them the advice that combination therapy is good for you, because you said it is good for them, then they actually believe that you are a trusted professional, that it is good for them, and therefore they should be able to take it. Then we also inform them. We explain to them what exactly would be the possible side effects or adverse effects of that treatment. And if they experience the same, then they'll be able to contact you and they'll be able to guide on what are the alternatives that they can use. Now, these are just a reminder of the science that you can be able to tailor-make and try to break it down in a way that the patient can understand. The agents like vinagliptin, it has a renoprotective effects. There's science backing. Remember, he had those patients who are, I call them the Google patients. So when they come to ask you, so why should I take this? So it's good to have a little bit of the science behind why it is they need to be on a particular therapy. So we have the renoprotective effect of vinagliptin, especially even in patients who have had hepatic injury. We have evidence to show that SGLT2 inhibitors, the dapagliflozin, empagliflozin, that they actually reduce cardiovascular death and heart failure. So if there's a patient hospitalized, the treatment has changed and they are in hospital, then you need to explain to them why it is has the treatment changed and you want to lower their likelihood of being hospitalized for heart failure. Or if they're heart failure patient, you want them to remain as an outpatient. Let them take their medicine at home. So with that in mind, and to ask, these new molecules, of course, they come with an associated cost. So what guides you for those who have the various agents, the DAPA, the empagliflozin, the sitagliptin, vidagliptin, linagliptin, what guides you in what it is that you will consider as the treatment that will be selected for a patient? And also besides that, you might want to have combination therapy or have the patients on combination therapy. What do you think limits you from putting the patients on combination therapy? What guides your choice in what you keep, and what is likely to limit you in providing that choice to the patient? So I want to see that was my last slide. Okay, so Benjamin says there are patient factors. If you could elaborate, what patient factors is going to make you the cost? Okay, So cost is going to determine what it is you're going to choose, and the limitation. Valentine, you've highlighted that comorbidities are going to help guide. Yes, Theophilus, comorbidities, the EGFR, the availability. The choice guides is guided by standard care of practice, the renal function, compliance. You want something, a regimen that's going to be easy for the patient to comply to. Thank you. So at least I have some good feedback. I'm hoping comorbidities. Wakoli, I think the slides, PSK will organize how you share the slides. I will send them to Mbao if he already doesn't have them. The efficacy, safety, what is in the KML? Yes. What is recommended in the guidelines? Yes.
Dr. Just to for us to be able to sync in the conversation with what Dawa is going to be able to present, allow us to move the conversation now to Dawa's side. Then we'll come back to the Q&A session.
Yes, thank you. So
Asante. Thank you very much, Dr. Aywak. Ladies and gentlemen, allow me to welcome none other than Martin Mugira. Martin is representing Dawa Life Sciences. Martin, take it over.
All right, okay. Thank you very much, Bao. Thank you, Dr. Thank you, everyone, for joining in this webinar. So on behalf of DAWA, we really would want to thank PSK for giving us this opportunity to partner with you. So this evening, we are going to just spend the next 10 or so minutes, 10 to 15 minutes, telling you about two of our products that are aligned with what Dr. has been talking about in the last 30 minutes. So I believe most of you must be knowing DAWA. So DAWA Life Sciences is a local manufacturer. So we are basically committed to, sorry, I'm trying to, you all can see my slides? Okay, all right.
Yes,
so yes, so at DAWA, we are committed to supporting your patients with the latest treatment options, and particularly in the areas of chronic diseases, metabolic diseases, diabetes, and cardiovascular, which are not only affordable, but also of high quality. All right, okay, so let me start by very quickly just showing you the EASD and ADA guidelines, which Kenya National Diabetes Clinical Guidelines have borrowed heavily from. And just as a reminder on what Dr. has talked about, so we know that the first line recommended therapy for diabetes patients is metformin, which should be accompanied by comprehensive lifestyle adjustment. But this is if the HbA1c is not above target. So we know that if it's above target, the recommendation is to move to the next level, like Dr. said. But also the other thing to consider is if the patient already has an atherosclerotic cardiovascular disease or chronic kidney disease. Also, you may want to have a consideration on whether the patient has a compelling need for minimizing weight gain. And I think Dr. has talked about this. We all know that most of the diabetic patients already could be having weight issues. Okay, and finally, the last consideration is on whether there is an affordability issue. It's interesting to see that some of the comments some of you have made on Dr.'s question was on cost. So the reason why I'm showing these ESD and ADA guidelines is because as DAWA, we basically have something that can actually be useful for your patients across all those considerations. But today, for the purposes of discussion today, I'm going to focus on two of them. Okay. All right. So we know that most of the patients will present to the doctor when their HbA1c targets are way above 7, and therefore it makes great sense to start patients with a combination therapy with metformin and also with any of the classes that are listed here: DPP-4 inhibitors, GLP, SGLT2, or TZD. Now, so today, focusing on the talk of the day, DPP4s, we have launched our vildagliptin about 2-3 months ago. Probably some of you already know about it or were involved during the launch, which goes by the name vigliptin, quite an easy name to remember. So vigliptin, with the molecule being vildagliptin. Now, so we have the plain molecule, and we also have the combination molecule with the metformin. Okay, then for if the consideration is on a patient who has got atherosclerotic cardiovascular disease, or they have chronic kidney disease, the guidelines recommend that you should consider as an SGLT2 inhibitor for these patients. That is for one simple reason that these drugs, this class of drugs has been proven and shown to actually protect your patients from further cardiovascular damage. So for this class, we have a dapagliflozin, which goes by the name Dapaflo. Again, a very easy name to remember. Dapaflo from dapagliflozin and Flo. So the two, I mean, the name picked from rhyming quite well with the molecule named dapagliflozin. And we have the full range, both in plain form and also in combination with metformin. Okay. Now, so just to give you a little information about vigliptin and also Dapaflo. So I won't be spending a lot of time on slides that Dr. has talked about, because I have some slides that are quite similar to what she had talked about. So, but just to remind you very quickly in terms of the mechanism of action, I know she has spent quite a bit of time on this, but I think it's always good to highlight. The way vigliptin works is by inhibiting the DPP4, which, as Dr. has explained, we know is the enzyme that is involved in deactivating the GLP-1, which is basically the good guy that we want, because it causes glucose-dependent insulin secretion and also glucose-dependent glucagon suppression. Okay, so the good thing about DPP4s, just to summarize what Dr. has said, is being an incretin therapy, it's considered smarter in terms of lowering glucose level, because it acts in a glucose-dependent fashion, unlike the sulfonylureas, which are basically insulin dependent. So because of this, then the risk of hypoglycemia in this class is just not there. And we know that in management of diabetes and in settings where mostly sulfonylureas are used, one of the biggest challenges is actually hypoglycemia. I think Dr. did mention that one of the challenges, because according to recommendations, you're supposed to intensify the therapy as much as possible to actually achieve the HbA1c targets as much as possible in order to protect these patients from end organ damage, macro and microvascular complications. But then in a lot of times, you may not be able to achieve this with the SUs because of the risk of hypoglycemia. So this is where DPP4s come. And I think as pharmacists, it's really upon all of you to try and convince your patients the reason why they probably need to pay a little bit more premium than sulfonylureas, because of the value and the benefits that they get from these drugs. So we also know that DPP4s reduce HbA1c modestly, but then if you combine them with metformin, the lowering of HbA1c is much better. And that's why right now, as you might be seeing in most of your prescriptions that comes to you, you will mostly find that they are in combination therapy. Okay. Then we also know that they are also weight neutral, which is a good thing that we want for diabetic patients. So this is one of the landmark studies called Verify, which probably you have heard about. But just to summarize, this is a study that was aiming to answer the question, should you start the patients in an intensified therapy of a combination therapy with DPP-4 plus metformin, or you should do a stepwise treatment where you start with metformin, and then once you have treatment failure, you add the second class. And the results from Verify study were very, very clear that if you start an intensified therapy of combination between DPP-4 and metformin, you actually end up with more patients, more number of patients who take much longer to treatment failure. In other terms, your patients will actually have you will have more patients with HbA1c targets which are within limits for much longer than if you do stepwise kind of treatment. So this is basically becoming like standard of care. And we also know that in our setting, most of the patients also most of the times will come with the HbA1c targets that are much higher than 7. Okay, so that was vigliptin. Now, what about Dapaflo, which is our dapagliflozin in the class of SGLT2? So as you can see, the packaging is great. Once again, we have the full range. We have the 10 mg, we have 5 mg, we have 5 with 500 mgs of metformin, and we also have 5 dapagliflozin and 1000 milligrams of metformin. Okay. So Dr. has explained about how SGLT2 work. This is how Dapaflo works by basically inhibiting the SGLT2, which is the SGLT2 molecule, which is responsible for the reabsorption of glucose. Okay. So allow me to just mention a landmark study called the DAPA-HF, which was done in 20 countries, 410 sites, and with more than 8,000 patients. So a very powerful study. And what was the finding of this study? So this study basically showed the conclusion was that if you put patients on dapagliflozin, whether they have diabetes or they don't have diabetes, but they have heart failure, you drastically reduce, cases of heart failure hospitalization, which we know that for heart failure, one of the biggest challenges is hospitalization, repeated hospitalization because of complications. And then also there was a drastic reduction in terms of cardiovascular death. And that is why these days, I'm sure you have seen this from the prescriptions that come from you, that most of the heart failure prescriptions will be having one of the SGLT2s, dapagliflozin, as part of the standard of care. Okay, so this basically says more or less what I've just showed, different way of analysis, but as you can see in the study analysis, dapagliflozin was much better in terms of CV death and heart failure hospitalization. Okay, so in a nutshell, what Dapaflo and also the others in class will give you is a 13% reduction in all-cause death, 14% reduction in cardiovascular death, and 26% reduction in heart failure hospitalization. So these were the key conclusions for this landmark study. What about patients with chronic kidney disease? Does dapagliflozin have a role? Absolutely, yes. So once again, patients were enrolled who had chronic kidney disease with or without diabetes. And the findings were that dapagliflozin delayed the initiation of dialysis and also reduced the number of deaths. Okay, so as you can see the graphs there, so 39% relative risk reduction from end-stage kidney disease, renal cardiovascular death, and also that 1% relative risk reduction for all-cause mortality. So very impressive results, very impressive results. And this is one of the reasons why dapagliflozin and other SGLT2 inhibitors are becoming part of standard of care for heart failure patients. So in conclusion, for DAPA-CKD in patients with chronic kidney disease with or without type 2 diabetes, dapagliflozin significantly reduced kidney failure risk, reduced the risk of cardiovascular death and hospitalization, and also increased prolonged survival for these patients. And I think as clinicians, this is what you want for your patients. And therefore, my hope is you can play your small part in making sure that your patients are using these newer OADs that gives them these great benefits. Okay, as I finalize in the next few minutes, we know that diabetes is an expensive disease. I think some of you mentioned that cost is an issue when you're considering what to give to your patients. So for DAWA, as you know, we are local manufacturers and we promise affordable solutions. Okay, so for DAPAFlow, the average cost I can give you for daily daily dose is about 110 shillings. Of course, this price may fluctuate a little bit depending on where or who you're buying from. But you can attest that for such a new molecule like this, that has got so much benefits that we have talked about, this is not a super high price. Okay. Then for vigliptin, so we have got the same price for all of them at about 75 shillings per tablet. Okay. And then the other thing that, of course, you may be interested in is to know whether they are quality products. Absolutely, yes, we can guarantee the quality of our products. And I think as pharmacists, probably some of you might have worked in DAWA during your internship. And you then would attest to what I am going to tell you in the next few minutes. So one of the things I can tell you is that our drugs and especially vigliptin and DAPAFlow that I mentioned about are developed and manufactured according to the WHO quality standards. We have compared these products with the originator in a certified WHO pre-qualified lab, and we can tell you very confidently that these drugs are similar in terms of quality. So where does it start? So our quality starts all the way from the time we are ordering for active ingredients, and we make sure that the APIs are ordered from very reputable manufacturers. Then after that, the ingredients are tested to see whether they comply with the BP and USP. Okay, and then in terms of packaging after production, we have packaged them in a very high quality packaging material. This ensures that they are protected from harsh environmental conditions, and this guarantees long shelf life. Long shelf life stability, of course, within the stipulated shelf life for the molecule. So our assurance is that our pharmaceutical quality system is much stronger and it's very rigid. Whatever doesn't pass quality control is, of course, doesn't get to you. So the only thing that comes to your pharmacy is what has been certified to be of good quality. Okay, all right. So as I finish, this is the prescribing information. The dosage for vigliptin, as we know it, is 50 mg twice daily, and you can combine these with metformin, vigliptin M, again twice daily dosage, 100 milligrams daily divided in 2 equal doses, and for DAPAFlow, 10 milligrams once daily. But if in combination with metformin, you can give 5 milligrams combined with metformin, 500 or 1000, again, twice daily, depending on patient individual needs. So that's it. Asanteni sana for listening. So Mbao, over to you. I think we can take questions.
Wonderful, Martin. Wonderful presentation. So probably I take us back to the conversation that we began. What what is our role as pharmacists in terms of UHC, and probably to have that conversation. Now, if we first answer the question, we first go to the Q&A section, and for the Q&A section, allow me to call back Dr. Aywak, and probably I'll go directly to the questions. The first question is by Peter Minor. That is probably supposed to be on a chat. So an anonymous attendee asked, taking in mind the long-term effects of diabetes to other body organs, is there a way we can have drug combinations that at least can be of vital protections to these organs in combination with anti-glycemics? Dr. Aywak, over to you.
Okay, thank you for that question. The presentation today was basically telling us the other drugs, the other molecules we're using, which we have found they have benefits in terms of renal protection, cardio protection. So that's what you're going to add so that you can give the benefit of reducing the likelihood of the patient having combination. We started off by saying we were used to metformin alone, but now we've realized the other molecules which can help boost as anti-diabetic agents and also offer an additional benefit of either being renal protective or cardioprotective. So what we have, the molecules will just actually say answer the question that you have asked.
Asante, Daktari. So probably the second question on that is diabetes in pregnancy. Kindly comment, Dr. Aywak.
Okay, that's quite broad. So I don't know whether it's comment whether diabetes happens in pregnancy or whether the question is what is the therapy choice in?
Yes.
Therapy choice. So if I say the guidelines, the diabetes clinical guidelines, I'll also share this with Pao, you can circulate. They recommend that for treatment management of diabetes in pregnancy, insulin is the medication of choice. But you can also manage patients on the oral glycemic agents like metformin and glibenclamide if the sugars are well controlled. But the drug of choice is insulin. We're together?
Oh, absolutely together, Dr. So only, what are the side effects of Dapaflo and vildagliptin? That is from Naomi Jenga.
I don't know whether he's asking Martin.
Martin probably will come in best with their experience in the marketing of that. Martin?
Sorry, Mbao, could you kindly repeat the question again? Sorry.
What are the side effects of vildagliptin and Dapaflo?
Okay, all right. So, so as we know it, and Dr. feel free to chip in here.
Okay.
So one of the advantages of vildagliptin and gliptins as a class is because they are glucose dependent, they work basically the way the body works, right? So the side effects are very, very minimal. Very minimal. Like we mentioned, one of the biggest issues in with diabetes treatment that has been used in the past is hypoglycemia, which is not there with the DPP-4s, vildagliptin as well. So, but there is some recorded minor side effects which could be rare. I think I don't have that at the top of my mind right now.
I could assist you there.
Yeah.
So, okay, so when they are looking at the dapagliflozin, those are the gliflozins. I like to think with the simpler names. So the side effects would include, most of the patients talk about mycotic infections. So you'll have a lot of female patients complaining about candida. Then there's also the risk of dehydration. Remember, it's encouraging fluid loss. So there's a risk of dehydration. When you're talking about the gliptins, the DPP-4s, then there's a risk of urticaria. That's the skin reactions and acute pancreatitis. Now with the DPP-4s, if the particular DPP-4 is not very selective for DPP to inhibit DPP-4, and there's DPP-4 and DPP-8. So if it's not very selective for DPP-4 and gets on the DPP-8, then you're more likely to have the skin, those adverse effects that are related to the skin. But otherwise, for both of them, they are weight neutral. So I want to hope that that has answered.
Yeah, and just maybe to add one thing, Dr. For the SGLT2s, you'd understand why the side effect that Dr. has talked about, which is mostly urinary tract infections, because with the blockage of reabsorption of glucose, then you have got a lot of glucose being passed through urine, right? And that's basically the cause of that side effect.
Wonderful, wonderful. So probably, Dr. Aywak, as you give us your parting shot, there's a question from I see your chairperson at HOPAC, Dr. Hilary Geshuki, is asking, thank you, Dr. Aywak, for your wonderful presentation. What's the recent post-marketing surveillance data on SGLT2 causing DKA and gliptins increasing the incidences of bone fractures? Your comment on that, Dr.
I want to hope that he has the answer for that one, but you know, there's no drug which will not have an adverse effect. So you have to remember, we are thinking about what would benefit the patient, what is the patient versus the risk versus the benefit, because others will not take any medication. I've seen also a question about glibenclamide. I've said for the guidelines that in pregnancy, the treatment of choice would be insulin. But remember, the patient has to be motivated to use it. So sometimes if the patient is not going to be motivated to use the insulin, and we know diabetes is very dangerous in pregnancy, they'll go for the oral agent. So the guidelines as of 2018, they still have metformin and glibenclamide, but glibenclamide has a very high risk of hypoglycemia, which is, so now you would want to discourage using sulfonylureas. For the study on I think probably my chair can be able to give a comment on the same, but usually I'd want to ask how many events were reported in one population so that we don't create panic like the time we did when HCTZ. We had a few events reported in a Scandinavian country, and then now it scared a lot of health workers from using the HCTZ and recommending the therapy. So because I've not seen the paper and I don't know how many events they were, I cannot really quite adequately comment on that.
Asante. So probably to comment from the chairs, HOPAC chairs, comment is that glibenclamide has a very long duration of action. He has commented on that, on the duration of action of glibenclamide. So let me look, allow me to try and look for it right away.
Yes, it has a very long duration. That's why the risk of hypoglycemia is quite real with glibenclamide.
Wonderful, wonderful. I also, yes, apart from that, in my practice, Dr. Valentine Intore, that is Meru County, PSK Meru branch. Urticaria is a common side effect with gliptins, and I have observed with patients. So any comments on that, Dr.
I want to encourage Valentine to please contribute to the local data by reporting. You know, a number of time effects and the profile in terms of the literature, but we are slow to document. Then when we look for our own local statistics for the same. So I want to encourage Naitari to please document so that now we can say, indeed, this is a serious issue. So we have to ask ourselves, is there a patient population? What is it that makes, what's the risk? What is it about this patient? Or if also, you have to remember that choice of gliptins. What is the choice of gliptins you've picked? Is it one that is selective for DPP4, or it also has a high affinity for DPP8? So there's a lot of that you have to put in. Take into account.
Asante, Dr. So I'm looking for one question by Dr. Dagane Dabal from KEMSA. He's asking for a combination of metformin and sitagliptin and the urticaria. What will be the change or the change of drug? What drug will we change? Will you advise us to change?
Now that they've already said that urticaria, and you know urticaria will come from the gliptins, that means you're going to stop the combination, move to the there's the other agents. Remember the choice of agents. So you go SGLT2. You know, you make these decisions guided with the patient choice, because there's also an associated cost. Remember, the patient will not take a drug they don't feel motivated to take.
Absolutely.
So that you'll have to think of what else do you have available in the facility? What can the patient afford? You can't use the gliptin. Can you use insulin? Can you use the pioglitazone? Do you now use the GLP-1 inhibitors, agonists? So it depends. You will have to go patient by patient, because if you look at the in order to send with you the KDIGO guidelines. It tells you for the patient if cost is an issue, what is the preferred treatment regimen and what is the alternative, what is the less preferred. When it is an adverse effect is the issue, what is the preferred, what is the alternate. So you'll have to really individualize.
Thank you, thank you. So probably, Dr. allow me to now get back to Martin. Martin, probably what is your party shot for tonight? As we're probably coming, not to an end, but to the middle part of our conversation tonight.
All right, okay. My parting shot is simple. I think we have, Dr. and myself, we have basically shown you the benefits that your patients gets from these two classes of drugs, fairly new in the market. Of course, you know, they have been there for quite a number of years now. We know that there is also a cost premium attached to it compared to what has been used previously. And I think as pharmacists, we play a very key role in motivating the patients. Because sometimes I'm sure you will find a patient coming to you, and once they hear the cost, they ask you whether there is an alternative. Maybe can you ask the doctor to change because I can't afford. I think you really have an opportunity or an obligation to try and motivate the patient based on the benefits that you know your patients will get from these drugs.
Wonderful, wonderful. Dr. Aywak, what is your parting shot on that?
I agree that from today, I'm hoping that we have learned the various regimens, and we are going to actually, when at the point of providing care, we are going to be able to explain to the patient clearly and help them make informed choices and motivate them to actually take the therapy. And for when we have identified side effects, adverse effects, please let's report so that we have local knowledge. Thank you.
Finally, Mbao, sorry for coming to you again. Very finally, I would like to mention that we have these two products, Vigliptin and Dapaflo, in the market. Please, if you would like to have them and you don't know how to get them, feel free to get in touch with us. I'll give my contacts, or you can reach to any of our representatives. And thank you to my colleagues who are in the call today. And we should be able to direct you where to get Dapaflo and Vigliptin. Thank you.
Asante. Ladies and gentlemen, we've come to the first close of our event, of our meeting tonight, but we're not yet closed because out of the conversation that we began when we were starting this webinar, I asked some few questions, and I asked, what is our role as pharmacists in UHC, in probably attainment of UHC? And the major factor that was coming out closely is probably the cost, being able to provide to our patients, to our clients, affordable and cost-effective healthcare, and also our patients being able to afford these drugs when need be. So, ladies and gentlemen, we're beginning this conversation now, and we're going to have a detailed conversation on this at the Pharma Supply Chain Hybrid Conference. It's going to be at the Strasbourg Business School for those who will be able to join us physically, and we encourage you to join us physically. For those who are not able to join us physically, it is also going to be a hybrid conference. So we will be sharing the registration link for the conference with the time, and we'll be able to share these details, and you'll see them. Apart from that, the link, the presentation today by Dr. Aywak, I will share it also online, and I will be able to share it with all who have joined us for this webinar tonight. Apart from that, ladies and gentlemen, I have a very important guest tonight, and I will request him to be able to give us his closing remarks for tonight. Ladies and gentlemen, allow me to welcome none other than the interim CEO at PSK, that is Dr. Lucas Nyabero. Dr. Are you with us? Dr. You can put on your mic, audio, unmute. Dr. I still can't hear you. Unmute your mic. Select on the portion to use your sound. Select on On the portion to use your, on the mute part, to use the drop-down box there, Daktari, to see that you're using the computer sound and unmute your computer. Daktari, we still can't hear you on this other end. Not yet, Daktari. We still can't hear you. On the drop-down box where there is the mute, select the computer system. The system. Not yet, Daktari. You can try logging out and in again. Not yet, Daktari. So, ladies and gentlemen, as Daktari is trying to join in, I assure you that all who have joined us today, we will be able to share the slides with you. We will be able to share the slides with you, and we'll be able to ensure that you get all these slides. So probably for Martin, you can write down, write your email address on your email address on the chat box, and probably even your phone number. You can leave it there for people to be able to get that.
Okay, all right, doing that right away. Thank you.
I will have kindly, ladies and gentlemen, don't put the emails on the chat box. I have all your emails since you registered for this meeting, and I will ensure that I'm able to get you that. So this is to welcome all to the conference on the Pharma Supply Chain Conference. We're going to have the discussion, what are we doing as the pharmacists to ensure that the drugs are cost effective, the drugs are efficient, the patients are getting the drugs efficiently. What will we do to ensure that our patients are able to access the drugs in such? So ladies and gentlemen, please join this conference on the Pharma Supply Chain. It's all on our social media sites. It is in your SMS and WhatsApp groups. Ensure that you join in for this conversation, since here is where we're going to carry on the conversation. For the tokens will be sent for KPA members. The tokens will be sent to your portal, and for PSK members, the token will be sent directly to you. So we are trying to see if Daktari is able to join in. Ladies and gentlemen, also probably to remind you is that we usually send the tokens to previous webinars after we send give or take within 2 weeks time. So we have not yet sent our tokens from the last previous webinars. I'm responding to Dr. Naomi Njenga. The registration fee for the supply chain conference is 2,000 for those who want to join us virtually, and it is also 6,000 for those who want to join us physically. So ladies and gentlemen, just from according to the CEO, his hitilafu za kimitambo hazijakubalisha tuweze kumsikia leo, na nitamsihi pale aweze kutuaga usiku. Daktari, you can probably wave at the members. Asante Daktari, thank you very much. So ladies and gentlemen, the CEO says he wishes to thank you for joining us today and in your great numbers, and assures you that we are going to collaborate with our various partners. Thank you very much, Martin, from DAWA. We are going to collaborate to ensure that we have these and more other meetings to ensure that we are able to give our Kenyan patient efficacious medicines when they need it and at the right cost at which they need it. So ladies and gentlemen, without further much ado, allow me to come to a close for this meeting, and probably for the young pharmacists who are asking, they will still get the CPD points. Na makweli nasema mara kwa mara kwamba lililo na mwanzo lazima liwe na mwisho. Tumefika tamati wa somo letu la leo, na mimi sina budi ila kuwaaga. Na nilifunzwa na mkubwa wetu mmoja hapa anaitwa Dr. Anthony Yaila, akasema nikiwaambia lamsiki mnaweza rejesha kwa msemo kusema binuru. Sina mengi ila kuaga, alamsiki.